Thank you everyone for joining today. Before we begin, I'd like to acknowledge that I'm speaking to you on the unceded territories of the Stowell people that is part of the Coast Salish region of southwestern British Columbia. For those who do not know us, the Manufacturing Safety Alliance of BC is the not-for-profit health and safety association serving manufacturers and food processors. We're here to assist you with your health and safety challenges with a competent team to help keep your workers safe. Take a moment to visit our website as we have a number of safety training courses and resources available, on-site or virtual engagements as well to provide specific needs to assist you, together with information on how to develop a health and safety management system to the Occupational Safety Standard of Excellence standards, core certification for the manufacturing industry. 2022 has had a challenging opening with the Omicron virus spreading so rapidly in our communities. The impact of such a highly transmissible virus has required us not only to shift back to COVID-19 safety plans, but also prepare for the number of vacancies that follow to address additional health and safety challenges brought on by these shortages. We've received many questions on how to manage through this wave most effectively, and have invited Dr. Schwant back, a medical health officer at Vancouver Coastal Health, to give you the opportunity to ask your questions directly. Thank you all for joining us. Unfortunately, Miranda Miller is unexpectedly away and unable to join the discussion. Michael, thank you for joining us again. Your time is very much appreciated. I'd like to remind our viewers to please use the Q&A icon at the bottom of your screen to ask your questions as we work through as many as we can in the time available that we have. We're being faced with many questions during this time, including what gaps are you seeing in the COVID-19 safety plans for Omicron that are contributing to transmission? What is the latest guidance on masks and ventilation? What questions about booster vaccines, their effectiveness and access to rapid tests for your staff, and return to work after acquiring Omicron? What are the guidelines on this? Michael, as our guests are entering their questions into the Q&A, can you provide some context on the current state in BC and what you're seeing, where you're seeing transmission, the most effective controls, vaccination status and effectiveness, new antivirals, and recommended return to work protocols for those who've acquired Omicron? Thank you and welcome.
Yeah, thanks for the introduction, Lisa, and for the invitation to come and speak with this group again. I'll give some introductory remarks and then looking forward to the conversational aspect of the morning as well. It's always a pleasure to talk to a very well informed and engaged group with this organization. In terms of the current state, again, many of you will be very much up on some of the latest and the data regularly presented on a provincial basis here in BC and also nationally and internationally. But for a little bit of context, as you're probably aware, we've seen record high case counts in Vancouver Coastal Health, where I work, and across British Columbia due to the emergence of the highly transmissible Omicron variant. So the emergence of new variants has continued throughout the pandemic, and the nature of evolution of selection pressure is that these new variants tend to be more transmissible rather than less. This is somewhat expected, and yet we don't know when and where and to what extent the emergence of these variants will plague us. So this is the emergence of the Omicron variant late in 2021, I think came at a time when many were not expecting it specifically, but the possibility is something that should really be anticipated going forward until we can really control transmission on a global basis. In terms of transmission in BC, we've seen data from the BC Centre for Disease Control presented by a provincial health officer that infections are likely to have peaked in the lower mainland, so in cities like Vancouver, Burnaby, Surrey, and so forth, and perhaps are cresting or still increasing in other parts of BC, but likely to be hitting that peak in coming days and weeks. This is obviously very good news, but in the meantime, we need to be very clear. There's not a sudden plummet in the number of cases. It's been a hard several weeks coming up this hill, and it will be the same going back down with a lot of transmission across the province. And even though we've seen on a case-by-case basis that this infection, Omicron, has presented a lower risk of severe illness than previous variants, it's important to keep in mind that very large denominator, the background number of cases. When that number is big, even a less severe variant can lead to a lot of hospitalizations, a lot of severe health impacts. We have seen a high number of hospitalized cases right now, largely among those who are unvaccinated, being a major risk factor, but also in some other groups that I'll talk a little bit more about. And we, for that reason, still have a number of different measures in place across British Columbia. The vaccine card being required for many public spaces like restaurants and gyms, capacity limits for larger events that have persisted. And as you'll all be aware, the requirements for COVID-19 safety plans in businesses and workplaces. So this is the current state as we find ourselves wrestling with this wave that's presented in a different way than previous waves of the pandemic, and it's required different approaches to managing it, but still that it's taken very seriously. I had a couple of preemptive questions about the effectiveness of vaccination against this variant. And I think really timely, of course, with the large number of cases that we're seeing and many people becoming eligible for their booster doses, receiving those invitations and taking them up. We've seen across BC with the same enthusiasm, really, as the first 2 doses, which is really quite excellent. Of course, this is a new variant, so the studies are coming in, I would say, on a week-to-week, almost day-to-day basis. One very large one that I've reviewed is from the UK Health Security Agency. And this is a study that found, looking at 3-dose coverage with mRNA vaccines, finding that these courses were 81% effective in preventing hospitalization due to the Omicron variant. So not as effective as for against the Delta variant or other previous variants, but still quite helpful. Being in a context with widespread transmission, that is a really good protection to have on board, and we'd certainly recommend it for everybody. And almost, of course, the vast majority of British Columbians are eligible. 2-dose coverage is found in the same study, the same UK study, to be around 65% effective. So it's still doing something, still something we would all want to have on board. This is a significant protection over being unvaccinated, of course, but it can be better still with 3-dose coverage. So again, really recommending that people take up those boosters when they have the opportunity to do so. The current state in British Columbia is we are finding that among people who are twice vaccinated, the risk of hospitalization is primarily in those who are 70 or older, people with immune compromising conditions. We've seen pretty few hospitalizations among twice vaccinated people without those risk factors. But nonetheless, you can lower your risk quite a lot by getting a booster dose. So again, when you have that invitation coming through, many of you, of course, already have. We see the statistics. Please do go ahead and do that. And we're trying to make this as readily available as possible, always looking at whether that's mass clinics, pharmacy, all different sites, and this varies across the province, trying to do our utmost to get this vaccine available to people. And the other question I wanted to touch on a little bit just before we get into the participatory part of the discussion is, when was this becoming endemic? Is this becoming endemic? Questions of that nature. Excellent questions. I think that's on all of our mind day to day. And really important to stress that there's not a firm criteria for the declaration of an endemic. It doesn't really proceed in the same way that there's a momentary formal WHO or national declaration of epidemic or pandemic status for a disease. The transition to an endemic period depends on a lot of things that don't happen in a single moment with a snap of the fingers, but really over time. Factors like the development of effective vaccines, the coverage with those vaccines, which of course can increase over time, being very important, and also the prevalence of immunity post-infection, which is not necessarily durable in the long term, but does have an impact in the shorter run. All of those things are very important. The waning of immunity related to both vaccine-mediated immunity or infection-mediated immunity is also an important feature. And then finally, as we've seen with Omicron, the emergence of new variants that can emerge, that can evade immunity, that is also very important. So the possibility of a transition to an endemic state is something that occurs over the course of time. And this has happened historically with other infections. But again, it's not something that typically is going to happen at any given moment. I think that we see features of it, such as the emergence of more transmissible but milder variants, the effective prevention of severe disease with vaccines that are very heartening in terms of a potential move in that direction. But this is not something that we just that we can just declare with the slope of a graph at any given moment. This is something that will take time. We need to see our way back down this way, and as well, I think with an approach that's I think cautious but balanced going forward. So those are some of the notes I wanted to share before we got into specific questions, Lisa. I hope that that's a helpful introduction, and really glad to get into the chat.
Thank you, Michael. And absolutely, I think we're all looking forward to hearing when it will become an endemic, but we don't have all of that information yet. But I think all of us are certainly welcoming that as soon as it arrives. One of the questions that we receive most frequently is really looking at the requirements for employees returning to work after recovering from COVID-19. Do you have any guidelines on what that looks like?
Yeah, the current state right now is that people who have been vaccinated against COVID-19, the emerging science is suggesting that people, for the most part, are likely to be much less infectious, in fact, likely not infectious at all, 5 days after their symptom onset. And this is the guidance that we're using for a return to work. So if someone has a positive test, we'd like to encourage them to look at that 5-day period. And this is the direction that people with a positive test would receive, and then can isolate at home during that time. And then at that point, people can return to normal activities. This is different. People who are unvaccinated, we're still seeing, and you'll see this in the BC guidance, a 10-day period, just because of the possibility of a longer period of infectiousness for that group. So that's important to keep in mind. And again, this is direction that will be available to people when they test positive. There's information that we try to keep updated on both the BC and then the regional health authority websites, directing people in what to do with that information when they test positive. But in terms of return to work, there's not a requirement for a negative test before coming back to work. And as well as that, I think, of course, people will have noted that this period has decreased, going from 10 days across the board to a shorter 5-day period. And this relates to the new data on the Omicron variant. There's ongoing research on the likelihood of transmission. We found that the risk of transmission, even with previous variants at 8, 9, 10 days post-symptom onset, relatively rare. And this seems to be even more so with the case with the Omicron variant.
When we're talking about symptoms, does that include the lingering cough? Because at times that can probably extend certainly beyond 5 days. Would you include that as part of that symptom group?
Yeah, that's a great point. People should have improving symptoms at that point, but the complete resolution of symptoms isn't required. We know that people can have, I think that post-infectious cough is something we've probably all experienced, whether it's from COVID or from other viral or bacterial infections. That can really linger, and it's not necessarily indicative of ongoing infectiousness. So that's something where people can continue to work. Of course, with all of the precautions that are in place per your COVID-19 safety plan.
Excellent. So other questions on the rapid COVID tests. Question coming in on really, is there any concern about relying on the accuracy of the COVID-19 test to determine if an employee with new and mild symptoms can come back to work?
Well, again, we're not using these tests as a gateway to return to work. So somebody who's had a positive test does need to be off of work, but we wouldn't use that positive or negative result as a return to work gateway. So this is one thing where the provincial recommendations around rapid testing are more for currently with the onset of symptoms, using that test, accessing a test if you fit the current testing guidelines. But again, if someone's off of work, they don't need to have a negative test to come back to work. We found with PCR tests in particular, of course, that positive results can stay with the person for quite some time due to viral material that might actually not be infectious. So some protocols that require 1 or even 2 negative PCR tests wouldn't recommend it. And in fact, we might find ourselves excluding people who aren't actually infectious.
Those that are utilizing rapid tests, there was a question that came in really on the application. So written instructions as it relates to 3 drops versus 5. I mean, if you didn't, because of the controversy on that was received from a particular individual, would that reduce the reliability of the results in terms of a negative versus a positive test?
Yeah, I mean, this is a great question because we're seeing more and more take-home use of these tests. So initially, these were more commonly administered by clinicians or trained non-clinicians in a workplace setting. the increasing use of these tests is to distribute people to take home and use at their discretion if they develop symptoms. So it's very important that the directions are clear, because of course there can be the accuracy of the tests can go down if they're not used per the manufacturer's instructions. So looking at some of the tests, I know there's a specific question on the PanBio test, which I think there was some documentation that suggested 3 drops, some that suggested 5 drops. 5 does seem to be the guidance. This is just for the person who would ask that specifically, or the people. So that reflects what the manufacturer's guidance is. If there's other documents that said 3, I would stay with what the manufacturer has said on that matter. Some of these will have some amount of leeway. These are tests to a large extent that are meant to be used by people in the home use, not necessarily by trained health practitioners. So if we're using them as well as we can per the guidance, I think we'll be in a very good space. But again, trying to look at that guidance, whether that's from the health authority that's distributed you the test or the manufacturer's guidance, if it's included in the box, as it were, I think that we'll be in a really good space. But just to that question, 5 drops does seem to be the appropriate amount for that PanBio test. And again, often the physical tests really give us a lot of guidance. If there's an actual well to put that fluid in, if it's not overflowing, if it's overflowing, it's quite likely you've gone too far. And I would take a close look at the directions in those cases.
Excellent, thank you. How critical are masks to prevent the spread of Omicron? Can you talk a little bit about that, in terms of the different types, the fit, and really to prevent the transmission of Omicron?
Yeah, I mean, there seems to be the science suggesting a pretty clearly emerging hierarchy of the effectiveness of masks. And I'd say from top to bottom, you'd be looking at a fitted N95 mask. Below that, a K95 mask, or not properly fit tested N95. Below that, you've got your medical or surgical masks. Typically, it's what we typically see in healthcare contexts. And then we've also got cloth masks, your 3-ply, widely described at this point, sort of 2 layers of cloth and one filter in between. And then you've got a whole variety of face coverings below that. So I think that we want to describe that well, and the science, I think, is increasingly specific about that ranking. So however, of course, one thing to note is the best mask of all is the one that you have and that you can use consistently. So for example, many people say that if they have, let us know that the cloth mask, they carry it around, they have a small supply of those, and those reusable masks have worked well for them. Some people have told me that their kids don't like paper masks and inevitably discard them. So I'd say a 3-layer cloth mask, 2 layers of cloth with a filter, probably a lot better used on the face than a paper mask tossed into the garbage. However, I think, again, we want to be candid about the science, which does give a very clear hierarchy of the effectiveness of masks.
Excellent. And when you combine that with ventilation, and I guess, the question looking at if you're in a ventilated area, more than 2 meters apart, can prolonged, respiration in a room with HVAC without wearing a mask pose a risk to those that are away. So, it's a bit of a layer, certainly, but, can you comment just on that interaction?
Yeah, the recommendations in BC, I think, have been pretty consistent. We should have ventilation in good working order and, in fact, optimized. So this really varies based on the building and based on the specific ventilation system, but you really want to make sure that you have the optimal amount of air turnovers that you can. It's a little hard to speak specifically to the numbers that you should aim for, specific systems and so forth. I know that there was an industrial hygienist who was on the panel but wasn't able to join, unfortunately. So I hesitate to go into a technical description of all of the potential options there. But I think that the general guidance of making sure that the ventilation is in good working order, very, very important. And in fact, optimizing if you have the option to improve, to build on it. And this is, I think that for some buildings, for most modern buildings, we find that when there's actual measurements taken in these sites, that they're usually quite good. Some buildings, some sites that don't have actual modern HVAC in place, they're ones that might suffer, and you might need to have might want to consult specifically on what you can do to optimize that.
Excellent. Thank you, Michael. Looking at the current requirements for employers to notify staff of a COVID-19 exposure, do you have some comments on that in the workplace? What the current protocols are?
Yeah, so right now there's not a requirement for workplaces to notify the staff of an exposure of COVID-19, and this is similar for other infections. We would say historically for most of the pandemic, we've let workplaces know. Public health will do that work. If there's people who are infected who need to isolate at home, or their contacts who need to isolate at home, we'll be able to contact people. The current state with the COVID-19 infection, British Columbia, and I'd say globally, is that due to the rapid generation time, the short incubation period, and the generation of new infections from COVID-19, is that sort of contact tracing at a population level hasn't had the same effectiveness with the Omicron variant that it has with other variants. And quite unfortunately, as someone who's spent the better part of 2 years working closely with contact tracers. So this is a tool that just doesn't work the same way that it used to. So we don't have public health making all of those calls, alerting everybody's close contacts and so forth. So this is why it's very important to have in place healthy workplaces, good safety plans that limit that risk in the first place, and really look at different layers of protection rather than the contact tracing, which just isn't able to have the same effect that it did before.
Excellent. There's a question that speaks about international travel. So, a known employee traveling outside the country, would you recommend an isolation period upon their return? Is that still, in place even with the current controls that they have on international travel today?
Yeah. For return travel, I think that we have a regularly updated set of requirements from Public Health Agency of Canada, from CBSA, Canadian Border Services. I would make sure that your employees are following those, make sure that they're aware of those requirements. We don't recommend that companies go above and beyond and impose measures beyond what the Public Health Agency of Canada has done. They're looking at these very closely, following international data, quite cautiously in many cases on COVID transmission abroad, and the various requirements for vaccination, testing, and potential quarantine on return. I think taking the guidance directly from the federal government on that is more than adequate.
Okay, thank you. Looking at the length of time a person could potentially test positive for COVID-19, can they continue to test positive for up to a month, or what is the range of that that you're seeing from the data?
Yeah, they can. I mean, we've seen that many people will be, quote, clear. We've seen people having repeat tests, sometimes for return to work, sometimes even related to their clinical management, and all different reasons. Sometimes people might be clear even within their period of infectiousness. We've seen that, and we've also seen positive tests persist for weeks, even months in some cases. So I think that varies to a really large extent from patient to patient. So it's hard to give a single number, and this is why we don't like to use the PCR test as a measure of clearance or the end of infectiousness, because we know it often can extend for quite a bit longer than that.
Okay, thank you. Looking at some of the positive things that we're seeing from just the antivirals that have come from the discovery of and the benefits, obviously. Do you have any information about the antiviral medication that has been developed, and do you see this changing, the isolation or monitoring guidelines going forward?
Yeah. First of all, the emergence of these therapeutics is extremely exciting. I've got to say, as I mentioned, our contact tracers are not necessarily doing the same isolation and quarantine direction that they were doing previously in the pandemic, but instead, a lot of our work is actually reaching out to people who test positive and have risk factors of being unvaccinated, for example, having immunocompromising conditions, other reasons that would make them potentially beneficiaries of these treatments. So we have our contact tracers involved in the quite rewarding experience of phoning people up and helping to form a pathway to treatment for them. And we hope for people with these risk factors that this can shorten the duration of their infection, of their illness, that is, potentially even reduce the risk of hospitalization or death. So this is, I think, a really exciting period that we have these available. And I say this as the prevention doctor, not necessarily the treatment doctor. Having this available to prevent further progression of infection is exciting from everyone from public health to ICU clinicians. I think every step that we see in these treatment modalities is very exciting in our field. In terms of reducing the need for quarantine, I don't think that would change things. If somebody is diagnosed with COVID-19, even if they get on that treatment, we'd still be recommending a period of quarantine or isolation. due to that infection, regardless of the treatment. We don't have good data yet that that treatment would limit their infectious period. That might be the case for some other infections and treatments, and we'll see over time if that turns out to be the case. But for now, we're really seeing that as a benefit for their potentially for their clinical improvement, but not a tool that would allow someone to avoid quarantine.
Excellent. Speaking to the immunity, how long after testing positive are you immune? Is it a period? Can a reinfection occur? What is the data showing us on this?
Yeah, really important question in terms of people's decisions to receive a booster vaccination and their ability to participate in different activities if they might be unvaccinated. The US CDC right now is currently using a 90-day approach, that if somebody's been infected, they're considered to be, for most purposes, to be effectively immune, at least on the order of vaccination, treated in the same way for 90 days is what's being used. So this, in terms of the science of when we would recommend a booster dose to someone post-infection, and whether or not they, for example, needed to follow various precautions, that's I think, a very reasonable timeline. This varies quite a bit, though. I think that many times people ask, I've been recently infected, should I receive a booster now versus later? For the most part, I think 90 days would be quite reasonable. People who are in a very high-risk setting, though, people working or living in long-term care, I'd give that example. We'd often say getting that booster on board sooner might still have an added benefit. Of course, that comes with the possibility down the road. We've seen that there might be more boosters, of course. So we want to make sure that we're being reasonable with people, I think, as well. So that I think that 90-day approach post-infectiousness, post-infection is, I think, a reasonable approach that the US CDC has taken.
Excellent. Looking at the different types of tests, and there's a comment or a question on the throat versus the nasal tests. Is there a difference in effectiveness from where you take the swab?
Yeah, you'll see if you look at the directions that are given for different products, they vary quite a bit. So I wouldn't be able to say, for rapid tests generally, that the nares, the front of the nose, is better than the cheek, is better than saliva or any other. Definitely, we found that the nasopharyngeal test, so this is the back of the nose, the brain swab, as some people have called it, seems to be the most effective in gathering viral material, and this is why it's widely used in the PCR test, where sensitivity is the goal. For the rapid antigen tests, one of the important features of a screening program, or for testing at high volume, high throughput, especially for self-administered tests, is the ability to do it without any particular health training or expertise. So the anterior nares or even cheek swabs are preferred. So I would say for a given test, again, we want to follow the directions for that specific test, whether it is advising a nasal swab or a cheek swab, saliva. That is the way that test will have been validated. The clinical trials that have looked at its effectiveness and led to its being licensed will be described in the method. So I wouldn't go off label and apply a test that's where the direction is to use the nose and applying that to the cheek or vice versa. Really, each test has got its own directions, and that's the way that we should proceed. The majority of those that we're seeing, the tests that are being deployed in BC, are what we call the anterior nares, front of the nostrils. And again, just looking at the directions that are provided would be the best way forward.
Thank you. Thank you for that detailed response. Looking at now the order itself, I know there's been some questions. We've had actually several questions into our organization that the actual order on the requirement of COVID-19 safety plans isn't on the website. I know there's some information on WorkSafe BC. So recognizing this, how should the employer proceed? Should they just react follow the previous order when the COVID-19 requirements were in place, or what are your thoughts on that question?
I mean, that's of course heartening to me as a public health official, knowing that people are on the website looking for that information. And I recognize the challenge when it's, the updates. Sometimes we see something that's coming in an announcement one day, and it takes a day or two before that's backed up with the sort of rich technical support that we try to provide online as a field. So whether that's the provincial health officer, regional health authorities, WorkSafe BC, getting documents out that reflect the current state of both orders and guidance is very important. So we hope that those will be available very soon. I can say that we anticipate that those directions will largely reflect what was required in previous COVID-19 safety plans. That would be, I think that if you start with that, use that as a starting point. Of course, you can work with your regional health authority, contact them. We've reviewed so many plans over time. We're grateful when we get the opportunity to, so don't hesitate to reach out to confirm if the plan that you've developed is appropriate. We'll definitely do that. We have a team that's able to do so. But I think that, again, the COVID-19 safety plans that applied during previous waves of the pandemic would be a good baseline for this, pending potential new directions that might be in the forthcoming WorkSafe guidance.
Thank you. And just a related question really speaks to, the reasons or what is the reason for changing from a communicable disease prevention plan back to the COVID-19 safety plan? The risk level I would expect, but really hearing from you on this.
Yeah, I think that right now we've seen, again, that move previously where we scaled back from the COVID-19 safety plan, I think tried to enshrine some of those good practices into communicable disease plans more generally, which is the direction that we've seen previously from the province. There's no question with the increasing number of cases that this is, I think it's been seen as an opportunity and a necessity, in fact, to take a closer eye at our approaches in workplaces, make sure that workers are well protected. So I think that this is just a matter of the changing epidemiology right now, the risk of transmission, that is. And I think that overall, most workplaces, from my understanding, did not dramatically scale down their approaches over time. So I think that again, this is just a matter of trying to, in some areas, we try to respond to the data, and I think tightening up, if you will, the requirements is just a matter of, I think, quite natural when we see more cases, natural and appropriate, really.
Yeah, and hearing from our members, we heard the same thing as many just continued through the summer last year, which we're very prepared to kind of flex and adapt to the changing risk conditions, which was really great to see. It was much more fluid. A question on the retention of medical records as it relates to visitors coming into having health checks. Do you have any comments on how long those records should be retained? Do you have any thoughts on that?
Yeah, good question. We get this a lot from, I think restaurants would be one where historically people were keeping contact tracing information for people who came through. Historically, we'd often respond to 28 days was reasonable. This happens to be 2 incubation periods of the virus, as measured with the original strain, some of the earlier phases of the pandemic. A month was also administratively, I think, useful for many. It happened to align well with I think, a pretty readily understandable and easy to implement approach. I think that would be just fine. I think that where those are kept, it's rare that it's going to be necessary for a public health perspective that we'll need to follow up on that information, but to the extent that it could be necessary, retaining that for a month would be more than adequate.
Okay, thank you. And one more related question to the return to work, just to reinforce the recommendations. Can you confirm if the return to work after 5 days is the same for both vaccinated and unvaccinated individuals for COVID-19?
Presently, the advice is that for unvaccinated people, again, that would be 10 days. Again, I would say not watch this space, but be sure to stay very closely tuned to both BC CDC, WorkSafe websites. We are in a pretty dynamic time, so updates are part of our week-to-week life here. But that's the current advice: is a 5-day approach for isolation for people who are vaccinated, and 10 days for those that are unvaccinated.
Okay, excellent. And really looking at related question, how about individuals who are close contacts, like fully vaccinated but cannot self-isolate? For example, they have an infant. What would be the return to work protocol? Is it the same depending on your the vulnerable groups around you?
Really glad you asked. People who are fully vaccinated and are close contacts to COVID-19 right now aren't required to isolate. They're not excluded from work, so they can attend. It's important that they monitor their symptoms, which we're all meant to be doing on a day-to-day basis. If they are symptomatic, definitely should not work at that point. People who are unvaccinated, though, do need to isolate as close contacts as they have previously.
Okay, good. Okay, excellent. And looking at that bubble, is that someone that everyone, even if you're not symptomatic within that family, would they be also have any requirements to isolate, or would they continue on as with their daily lives?
Yeah, so the advice for people who are contacts has changed in BC in recent times. And again, those close contacts, whether at household, casual, whatever the level, again, as long as they're vaccinated, they're not required to isolate.
Okay. And even with mild symptoms, I know we talked about this with coughing, but if they have mild symptoms and proceed with a negative test, can they proceed to work even with mild symptoms? Or I know we haven't talked specifically about this, the group of symptoms that you'd expect to stay home with, but do you have any just further information on what that would be for guidance for our employers?
Yeah, I mean, generally speaking, I would say with somebody, especially somebody who's been exposed to COVID-19, to have a relatively low bar. So somebody who has no particular known exposure, who has, for example, non-specific symptoms, mild symptoms, they don't necessarily have an absolute need to exclude from work. Although, of course, if they're feeling unwell and they're unable to work, we really think that there should be a low barrier to people taking the time off. Somebody who's a contact, though, this is why we still mention, even though there's not a hard requirement to isolate, we still recommend that period of self-monitoring, that added vigilance. So I think you naturally enough and appropriately should think about a very mild runny nose, potentially headache or fatigue, much differently if we've been exposed to COVID than if not. So I would think that any sort of symptoms that could be compatible with COVID-19 following an exposure would be a reasonable direction to exclude from work at that time.
There's been a number of inquiries about access to take-home tests. Is this something that how readily available are they today? And is there ways that we can, the employers can access them? What is the process around that?
Yeah, I think that we've had the opportunity to speak in previous webinars about the rapid testing program, and many different companies that are on this line I know have gone forth, requested to the BC CDC test through that program, received them, and have been implementing testing for asymptomatic screening at different times in the pandemic. I know the direction right now during the Omicron wave has really pivoted to try to get symptomatic tests to people so that they're able to test without attending a testing site, again, following the testing guidelines, of course. And right now we're expecting an increased supply. This has been something that's been described publicly by the provincial health officer, and it's the direction of that to different sectors, I think, will be the matter of provincial announcements. But we would expect that we're going to see, whether it's through workplaces, through more disseminated distribution, for example, potentially through pharmacy or other sites that we've seen in some different jurisdictions, we're going to have a broader public availability of rapid tests for symptomatic infection. But I think this is something that we're going to be looking to provincial direction for how that's going to be delivered exactly. But certainly workplaces will be understood as important sites of that, as they have been throughout our different approaches to rapid testing during the pandemic.
Is it possible to get more than one variant of the virus at once?
Well, at this point, there seems to be one of the features of the emerging variants is that they replaced each other so quickly that we haven't really had too much of an issue. Generally speaking, we had a brief period in December where there's maybe a 50-50 mix of Delta and Omicron at the same time. And although there does seem to be immune evasion, which is to say people who have previously been infected with Delta, for example, might not have full protection against Omicron, there does seem to be some cross protection as well. So I would never say never in COVID-19. I try not to, but I think that in the short run, certainly infection with one would be protective from another. That's, I think, fairly safe to say.
Okay, thank you. Is Omicron considered more transmissible outdoors than previous variants, would you say? Is there any change in that?
Yeah, I mean, it's going to be more transmissible, whatever the setting. Whether you're describing the household, a household, the risk is going to be higher than it would have been from Delta. If you're looking at a workplace, if you're looking at public spaces. So I think that that's important to keep in mind. So, but in some cases, you might be going from a moderate risk to a pretty high risk, which we've seen with a lot of people. Activities that were relatively safe, relatively low risk before, have been at a higher risk with the Omicron variant being so transmissible. But then activities that are of very low, almost negligible risk would be expected to be even a slightly higher risk. We wouldn't say that it hasn't changed, but it's still going to be very low. So being in a well-distanced outdoor space, pretty low risk to begin with. I'd say extremely low risk, in fact. So even if that's as mild as a much more transmissible variant in our midst, those double a very low risk is still a very low risk. So I think that we want to be mindful of and in fact promote lower risk activities, but being aware of where this more transmissible variant is a problem. I found in responding to cases and trying to understand transmission in our community that these areas of previous moderate risk are really where we've seen some of our, I think, the biggest increases in transmission. People who had metered out their activities per public health advice over time to one level of transmissibility. What we found, and I think that has been seen across the globe, is the transmissibility that in events that were relatively low risk previously, in some cases have been ratcheted up into a higher risk category, unfortunately. But outdoor activity, particularly with some distancing in place, still very low risk. And we hope that people are able to engage in both social connection, exercise, recreation, and all of those things outdoors and feel confident to do so.
Excellent. Those good news and good points are really important because social connections are critical, especially with just the extent and the long period of time we've had to live with, obviously, this pandemic. So looking at daily health checks, are they required? That was one of the questions. And if so, must they be documented? Is that a requirement under the current expectations?
Yeah. So there's a requirement for, I would say, a daily health check, but the form of that can vary a fair bit. And I think that in some contexts, we've seen that people, for example, healthcare workers, we have a requirement in concept for a daily health check, but we know that healthcare workers have a good sense of what the symptoms are that they're looking for, and so they would be self-monitoring on a day-to-day basis. Health checks at the door. In some cases, employers have found that it's important and it has a value add to actually ask people about their symptoms on a day-to-day basis. So right now, it's again not required that we have for example, a checklist, a staff person at the door monitoring for those symptoms at the entrance. But this is the relative benefit of that seems to vary between contexts. So the important thing is that people are not working while symptomatic, that they have the opportunity to take time off when they're sick, and the specifics of how that's implemented, whether with a person identifying symptoms, which they should be empowered to do, and potentially with the addition of screening at the workplace, varies from workplace to workplace.
Is there any ever obligation for the employer to do any form of contact tracing? You know, as an example, if they recognize that one has been infected with Omicron and they have been in connection with other employees, is there an obligation for the employer to do any of those contact tracing functionalities?
Yeah, no, we're really not recommending that from public health right now. That's not something that we're requiring. Workplaces are doing a lot right now to limit risk and following the directions from WorkSafe BC and from the provincial health officer. I think those are the core things that we're hoping for and that we're in some cases requiring of workplaces. But going into contact tracing of that nature, we wouldn't require or recommend. I saw a good question in the chat just related to that previous note on health checks at the door. Just to note that in some cases it can actually be helpful to an employee, to a staff person identifying symptoms who might not have realized that those specific symptoms could be a risk. And sometimes people, we might feel okay, and I'll be the first to admit to it. Sometimes you might be feeling fine or marginal on your way in, but if asked by a colleague, we've found over and over again that people in many cases will say, actually, yeah, when asked directly, face to face about this checklist of symptoms, people do realize and want to protect those around them. And again, if supported with time off, with the appropriate sick leave, we find that can be a helpful addition. So again, to that note in the chat there, if there's a benefit to adding a direct screen, we do encourage it.
Thank you. Looking at masks, and we know it's a layer of protection, an important one. Is it a requirement though? Are manufacturing production floor workers required to wear masks?
Yeah, and this really varies a little bit from workplace to workplace, and it relates to the other measures that are in place. So, for example, we do have some businesses where people are very well spaced out. They might even have their own area where they wouldn't be required to wear a mask. So it's not an absolute requirement that all workers in all contexts where there's another person present have a mask. for the most part, we would recommend this. I think that this is, if you're describing a manufacturing floor, I would say absolutely. You have often not only the very nature of the work, having some closer contact, but also just the to and fro, if you will, often putting people in unplanned closer contact as well. So in short, we would recommend when people are working in group settings that masking be in place. But in terms of an absolute requirement, there are situations where, for example, if people are working at great distance or in essentially separate spaces, that they wouldn't need to have a mask. And we sometimes find that, in fact, not being on, if you will, autopilot is actually quite helpful for people thinking about their COVID-19 risk. So if I'm in my room here at Vancouver Coastal Health, wearing a mask is probably not of much use to anyone around me. But I'm very mindful when I move out into the hallway, if someone comes in to talk to me, potentially masking as we come into closer contact. So again, I think that in short, yes, people working in group settings, please mask up. But again, being aware of what you're doing, what you're trying to accomplish at any given point with that mask is very helpful too.
Excellent. Now, looking at a very interesting question on transmissibility of the virus and humidity, is there any data to suggest that different types of humidity environments impact the transmissibility of Omicron?
Oh yeah, I mean, this is an absolutely fascinating discussion, and it probably will be going on for quite some time to come, because this virus or other variants of it, we're certainly going to be will persist in our societies. I mean, there's some experimental data that's actually suggested that that increased humidity might lead to increased persistence of the virus in the air. And then there's also data that suggested that drier environments, epidemiologically looking at meteorological measurements, have been supportive of transmission. So right now, I would say I don't think that there's an absolute certain reading on that, but it's likely that the humidity does have an effect. Again, some of the laboratories research that I've read has suggested that humidity might lead to a longer persistence. But again, we've also seen some, I wouldn't say contradictory, but there's as with all of science, there's an intersection of data that we need to interpret, and a lot of experts hard at work trying to do that.
Thank you. What a wealth of knowledge. Appreciate it. Other related questions. What percentage of the infection rate could be decreased after people get their third dose? Is there any predictions on what we're expecting based on the increasing number of boosters being delivered to individuals?
Yeah, I think that the third dose, a lot of the benefit that we're seeing right now is to that risk of hospitalization, of severe illness. So we're seeing that there's, again, I would say good, but not excellent protection from transmission with 3 doses. It's still possible to have infection. Sometimes it might be mild. Sometimes it might even be relatively what we would call severe sub-hospitalization sort of infection. People can certainly have what would say a pretty rough course with COVID-19. However, the third dose does seem to be very preventive of hospitalization. So I think that that's one of the main things, that even while COVID-19 may circulate among those who are once, twice, thrice vaccinated, that the prevention of severe illness in people with a second or a third dose especially will really help us to not overwhelm the health system, to not see those severe impacts at a human level. So I think that there's the transmission benefit, which is unfortunately with the immunologically evading Omicron variant has been less than it was with previous variants, but the prevention of severe disease does seem to be quite excellent.
Thank you. Another really interesting question is on viral load. Is there a relationship between the viral load and severe illness?
Yeah, and this is, again, a really good question. The viral load, even the relationship between viral load and transmissibility seems to be unclear. I think there's a lot of research that some that supports it, some that I think puts questions to that data. So it's, I think, an emerging topic, and it's been revised with the emergence of the Omicron variant. In terms of severe disease, same thing. I think that what we're finding is that the individual characteristics that might relate, in fact, to the development of the viral load seem to be the most important thing. So clinical risk factors like older age, other medical conditions that can put people at risk, lack of vaccination certainly are probably some of the most important factors. I think that those might in turn have a role in how the virus fares, if you will, after an infection. So again, the correlation and whether or not that's causal, I think, topic for ongoing research, as we say.
Excellent. Another question on vaccines, and is there a risk of increased sensitization from more and more additional booster shots? Are you seeing any of that, or is there any data that supports that potential relationship?
And not really. I think anecdotally, we found that people on with the second dose of some of the vaccine products, in particular the Moderna vaccine, have described perhaps that the reaction to the second dose was higher than the first. And this has been described with some other vaccine products as well, a sign that the immune system is primed, that the first doses have some effectiveness, I would say. In terms of sensitization to severe to adverse events, I wouldn't, that hasn't been something that's been detected in the data that we've reviewed, and we'd continue to encourage people to have their recommended vaccinations. Certainly the benefits seem to far outweigh the risks.
Okay, excellent. And we know that COVID-19 isn't the only virus out there. Any comments on just what you're seeing in trends with the other types of virus circulating in our communities?
Yeah, it's a good question. We were just discussing how the circulation of some other viruses perhaps does continue in spite of even with a global pandemic. So if we're talking about GI infections or other types of infections, your local public health programs have continued to work on that right through the pandemic. In some cases with some decreases due to the nature of different activities out there, but I would say that to a large extent, these things have continued apace, whether we're talking about Salmonella, Legionella, other infections that we're constantly following up in the background. There has been some evidence that, especially during 2020 with the relatively strict restrictions that were in place across society at different times, we did see decreases in the transmission of some other respiratory infections, some of the other things that are spread from person to person. Naturally enough, in the efforts to limit transmission of COVID-19, we also saw less influenza, for example. And I think that's quite natural when we would see that viruses that have transmission through relatively similar means are going to benefit from the same preventive measures. So I would say yes and no. Some things that are prevented, where we might expect with the mode of transmission has some similarity, and of course there's other things where we'd expect no particular benefit, and some of these infectious issues have continued apace.
Would you say that comparatively to former years, we still have a lower rate, to the flu and other types of illnesses that you're seeing?
Yeah, I would say, it's only January, so I knock on wood, but I'd say that we're looking now perhaps at our second year in a row of relatively diminished impact from influenza. But again, I don't think that we want to count any of these things out. We expect to see, as we move more and more towards normal function of society, which includes, I think, in a positive way, social contact, people working together, and so forth. These are infections that are endemic, things like influenza, for example. We have the ability to limit its impacts, limit its transmission and severe disease over time. But I don't know that the experience of the COVID-19 pandemic will have a lasting impact on some of those infections. They're likely to come back to the sort of the endemic levels where we had seen them previously.
Well, certainly hoping some of the good habits continue with behaviors, washing hands, all those things that we know are certainly prevention oriented. Looking at the boosters eventually be included in the expectation for the vaccination, proof of vaccination controls in the future. Do you expect that to be the case? Is there any discussion on that, whether you need to, that will be included in the vaccination proof of vaccination record where that is applicable today?
Yeah, there's two prongs to the benefits of the proof of vaccination. I think, or two prongs, is one way that we could summarize it, is that both there's the potential of decreasing transmission and risk to people participating in different settings. So if there's, if everybody present in let's say the theater is vaccinated, we might be able to reduce the risk of transmission. That benefit might be a bit less when we see that transmission is flowing relatively well with Omicron compared to Delta. Although again, of course, vaccination is still reducing transmission somewhat. Of course, and as well as the direct benefit of reducing transmission, we see the opportunity to encourage vaccination, of course, to participate in these different areas of life that there's been we've seen that these measures across Canada have seemed to result in uptake of vaccination. We've seen increases when these measures are implemented. Naturally enough, it's an incentive to be vaccinated. Now, I mean, these would be matters of provincial policy. Whether there's the opportunity to boost the uptake of the booster vaccine by making that a requirement or not. I don't know that we have good data, good information at this point whether or not that would be effective. So on either of those fronts, one, would it result in decreased transmission in these settings? Two, would it result in more uptake of booster vaccinations? I don't think that that's known right now. I think that we have not completed the phase of people even being invited for their boosters. So we'll need to see what has the uptake been of boosters. We hope that it will be that everyone has received a second dose in time will receive their third dose. And right now we're seeing pretty good movement in that direction. So I think that these would be decisions for the future state. And by the time that everyone's had their invitation for a booster, I think we'll be in a very different place in the transmission of Omicron. And as we all know, I think that we'll also we have no idea exactly what will emerge in terms of future variants either. So it'd be I think premature to say that will certainly or not or never happen. I think that it depends on a number of factors, and at least as long as we're aware of what those decision points might be, we can proceed with some anticipation of potential measures.
Excellent. And a final really interesting question: is there any protection transferred by a vaccinated blood donor to a blood recipient?
Yeah, really interesting question. And to my knowledge, this is not a transmission mode that's been recorded for COVID-19. Of course, globally during an emerging pandemic, I hate to say, as I often say, hate to say never, because there could always be a case that it's an exception to the rule or to one's understanding. But to my knowledge, that should not be a risk. I would not expect it to be a risk for transmission based on what we know of the virus.
Okay, interesting. And the kits available through the BC government website for individuals, are they the antigen test? Is that the test?
Yeah, that's right. Those would be rapid antigen tests. And there's a variety of different products that are coming into play. The supply chain questions, of course, are complex and changing, but there's the intent to distribute a large amount of rapid antigen tests for people's use in the home for personal use.
Okay, excellent. All right. So thank you. I just wanted to say a big thank you and an extraordinary discussion today. We're privileged to have you, Dr. Schwant, with us. Appreciate your time and a wealth of questions from our audience. So thank you for joining us. If we did not get to your question, we'll certainly do our best to respond to some of them in the follow-up from today's session. The recorded session will also accompany resources that include information to support the review of COVID-19 safety plans and mental health. I just want to remind everyone as well about some upcoming webinars. We're trying to certainly plan for many this year, so please register to join us. On February 1st, the Future Trends for the World of Work with the National Safety Council's John Donnie joining us from Chicago. Find out about employers are handling vaccine requirements and testing protocols and how workers feel about it, and plan for 6 workplace trends that will affect your business going forward. And on February the 24th, we have Working with Machines with Cobot Safety's Dave Smith joining us from Ontario. If you're using or considering automation, attend this session, please. You'll understand the risks and industry standards for working safely with collaborative robotics. Additional resources, as I mentioned, are available on our website. Please visit us online to access our checklist for reviewing your COVID-19 safety plan and a selection of mental health resources as well. Also, please watch for more mental health topics coming in our upcoming webinar calendar. Thank you so much for joining us. Please check your inbox for survey links to share your feedback, suggestions to help us improve future webinars. We'll email you tomorrow with a link to the recorded webinar and all of the resources. Thank you and take care.